Wow, they are all flooding in. Welcome, welcome. I'm going to give everybody a minute to get connected. It's so good to see everyone. Give you just a second. We have a bunch of folks joining us today. My name is Anissa Mitchell. I'm with PMD Alliance, and I'm very excited to have you all joining us today for our conversation with Dr. Joseph Quinn on preserving cognitive function in Parkinson's. It's a longer title, but it's a mouthful. So I want to encourage you right now to go ahead, if you would, go to the bottom of your screen and pop open your chat box. And that is where we're going to have you ask your questions today. We have a ton of people joining us, already over 200 people online with us today. We had well over 500 registering. So your chat is the best way for us to be able to go through your questions. But I just wanted to kind of let you know that because we do have a lot of people, and I anticipate that we are going to get a lot of questions. We'll try to do our best to answer as many of the general questions that are coming through that are common. So it may not be your specific question, but some commonalities in questions, because I'm sure there's going to be a lot. I would love it if you would give us a shout out like Mary did from Lake Havasu City. So please let us know, where are you joining us from, since we have so many of you joining us. So I want to go ahead and get us started. So we have with us today Dr. Joseph Quinn, who is a movement disorder specialist and Parkinson's Center Director at Oregon Health and Science University in Portland, Oregon. Now, his research focuses on cognitive decline in Parkinson's disease and other neurodegenerative disorders. And obviously, this is a very interesting topic since everyone is joining us today. So we're all anxious to hear what he has to say. So I'm going to welcome Dr. Quinn, and I'm going to pass this over to you.
Great, thank you. Let me see if I can get my slides up. Are you seeing that okay? And hearing me okay? Okay, good. Great. Well, thank you for the invitation. This is, as you pointed out, this is my area of interest, so I'm always pleased to go over it and kind of share things and answer questions. So I'm going to try to get through this in 40 minutes or so, and then we'll get to Q&A. And all right, there we go. All right, so here's what I'm going to try to cover. I'm going to try to say a little bit what we know about cognitive changes in Parkinson's disease. How common are they? What do they look like? What do we know about preventing cognitive decline? And then what do we need to learn, and really give you a little bit of an idea what kind of research is underway in this area. So starting off with what do we know about cognitive changes, this is a sort of a picture of by a famous medical illustrator about Parkinson's disease, and you can see the primary motor features on the left, the tremor, rigidity, bradykinesia means slowness, and then gait disorder or walking troubles. Those are the key features. And when Dr. Parkinson described this in the late 1800s, he was explicit, and this is a copy of his monograph, he was explicit that this is a motor disease and there's no cognitive problem. This was, actually, it was early 1800s. Now, at the beginning of a person's experience with Parkinson's disease, it's true that there's not typically significant cognitive troubles, but over time, as we've watched people with Parkinson's disease and looked at them carefully over many years, we realized that cognitive impairment really is actually pretty common in Parkinson's disease. And as the treatment of the motor symptoms has improved, cognitive impairment has really become one of our chief concerns. If we could prevent cognitive impairment, we think we could cut down on a lot of morbidity, a lot of distress. So when people first have a diagnosis of Parkinson's early on, it's a minority of people who have cognitive trouble, about 20%, and they have an entity that we refer to as mild cognitive impairment. And that means impairment in certain cognitive functions that's outside the range of normal, but not severe enough to call it dementia. And the prevalence of that level of impairment increases as Parkinson's progresses. But then dementia, this broad term that describes cognitive impairment that's severe enough to interfere with your everyday activities, does appear later in the course of Parkinson's disease. And, by 10, 15 years into the disease, some estimates are as high as 80% of people with Parkinson's disease. And the first thing you might wonder is, well, this is an age-associated disease. You're already at a significant age, typically when you're diagnosed with Parkinson's disease. Are we just seeing the aging process superimposed on Parkinson's disease? And the answer is, it's more than that. So even if we compare people with Parkinson's disease to people at the same age, there are several-fold greater incidence of severe cognitive impairment or dementia in people with Parkinson's disease. Now, it's not uniform. It's not everybody that develops this, but it's a big enough problem, and it's a long enough period of time from the time of diagnosis to the onset of these things that we really are focusing our attention on what we can do to prevent things from progressing in that direction. The cognitive troubles in Parkinson's disease are not identical to Alzheimer's disease. So it's not the same kind of illness. Alzheimer's is maybe the most common type of dementia that you've heard of. And what I'm trying to convey in this table is that the particular mental functions that are affected, and that shouldn't say Lewy body dementia, Parkinson's dementia would be a better term there, that in Alzheimer's disease, whereas memory is the predominant problem, memory is a little bit of trouble in Parkinson's dementia, but it's not as severe as it is in Alzheimer's. And the areas that are problematic in Parkinson's dementia are really attention, the ability to sustain attention. There's a group of functions that we call executive functions, and these are also tied up with attention and concentration and sequencing and that sort of thing. And those are things that occur in the front of the brain. And then in the back of the brain is where visual processing occurs. And visual processing is also affected with Parkinson's dementia. And so the appearance of the cognitive troubles in Parkinson's dementia and in this other entity, Lewy body dementia, is really quite distinct from Alzheimer's disease, which I think is what most people think of when they hear the term dementia. So that's what, some of the basics of what we've learned about this is that it's relatively common. It's got a sort of a distinct look about it that's different from other forms of dementia. And then I think the thing that most people are signing on for is to hear, what are some practical things we can do that we know will help to prevent cognitive decline in Parkinson's disease. And I know we doctors are famous for reaching for the prescription pad right away and talking about medications as the first thing. And there are some potent things we can do with medications, but lifestyle issues really can have quite an impact on the incidence of cognitive troubles. And I want to describe a little bit of what people with Parkinson's can do in terms of diet and in terms of activities, including exercise. And then after we go through those important measures, then we'll get to the medications next. So to start with the diet, I have to admit that we don't have compelling evidence for a Parkinson's specific diet, but we do know that everything that's good for the heart is good for the brain. So this quotation is from somebody who's a international expert in these things at Johns Hopkins University in Baltimore, and this summarizes really a whole host of literature about diet and exercise and the health of the brain. and how do we turn that into practical advice? Well, in terms of the diet, I steer people to the American Heart Association website. And the reason I do that is the American Heart Association is also the American Stroke Association. So everything that is recommended on that website has an eye to brain health as well. And the other reason I steer them to that website is it's very well developed in terms of lay-friendly recommendations. And I'm going to go through this in a little more detail in some other slides. But when people ask me, what should I do with my diet to preserve cognitive health, I really recommend this diet and the American Heart Association diet, which is looking more and more like the Mediterranean diet. And the key is to get a little bit of fish in the diet, to eat lots of fruits and vegetables, those are, and the fatty component should be minimized. Olive oil types of fat are emphasized. Some people seize on the wine in the background, and so that's, people get excited about the diet. But there's really very good science behind this diet. And as I say, this website, and I'll try to show you this in some slides, has a really good approach to recommending these things. So here's the diet in a little more detail. That link that I put up there, www.aha.org, takes you to this layperson-oriented site and talks about these 7 factors that have to do with heart and brain health. And if you click on any of those things that you see along that bar there, it will give you some more detail, and I'll show you what some of those details show. So the Eat Better link takes you to this description of the Heart Association / Mediterranean diet, where we're talking about lots of fruits and vegetables. So 4.5 cups a day, you have to kind of put your mind to get that. Fish a couple times a week, fiber-rich grains, keep the sodium down. And one of the reasons to keep the sugar down is promoting, late life diabetes is not good for the brain. So that's why I keep the sugar down as well. So again, this, I don't think I have too many other links on the diet part, but this website, if you click further and further into it, when you get under the Eat Better, it'll get to the point where it'll give you recipes to make. I mean, it really, it's very concrete. It's very specific, which is one of the things I like about it. Aside from diet, one of the other factors is activity. And when we think about activities that are good for preserving cognitive health, people tend to jump to the idea of mental exercise, doing crossword puzzles or something like that. And I think there's some value in that, and I'll describe some options in just a second. But I think just as important, and in my opinion, probably more important, is physical exercise and aerobic exercise. The effects that physical exercise has on the brain are quite profound, and we'll talk about that in a second. So in terms of mental exercise, one approach is to look at one of the allied health professions that can help with teaching you cognitive exercises and promoting cognitive exercises. So speech pathologists, the same specialists who help with speech recovery from stroke, the same specialists who help with swallowing problems, the same health professionals that in the case of Parkinson's disease help with increasing the volume of your voice, are also often trained in cognitive rehabilitation. So not every speech pathologist does it, but a lot of them do, and they really like to do it. So if you are looking for resources to help with these types of mental exercise, I would encourage you to speak to your physician about whether they have a speech pathologist that's available to do that type of rehab. There are other options online, and I don't get kickbacks from any of these places. I don't have any conflicts or anything. And I'm not saying they're a must-use resource, but but there are some reasonable options. So sharpbrains.org is an outfit that is kind of a clearinghouse for information on cognitive health and cognitive exercises that are available online. It doesn't cost you anything to just take a look at the website and see what's out there. When I have gone there, when I was on an email list at one time, they were giving pretty good information. They had an annual conference that was pretty good. So I think that's an area for a resource. People often ask me about this. The second one that I've listed under there on the online options, Lumosity. This is the one you see advertised on TV with some frequency. I used to poo-poo this because they charged a ridiculous amount of money. You had to buy like a year-long prescription for thousands of dollars. I didn't think it was really worth it. But the truth is they have fairly good science behind the program. And they have arrangements now where you can, for a very small fee, go a month at a time. And so I've encouraged my patients to give it a try. Some of them like it and some of them hate it. You know, it's a little bit tedious, but it is a well-done option, and you can try it out without spending a ridiculous amount of money. So that's another option. So those first two bullets are sort of things that resources that you don't have at your immediate disposal that you might, or now that I've told you, you do have at your immediate disposal, but they're not things that are in your everyday life. The third one is people say, should I do crossword puzzles? Should I, do X, Y, Z? And I think what I think works best is doing activities that you are enjoying, so mentally stimulating hobbies and games. If there's some social stimulation, so much the better. That's good for your brain as well. If you want to really get ambitious, you could, look into learning a new language or beefing up a second language that you have. Music, any of those sorts of things are the evidence is strong that maintaining cognitive activity helps to preserve cognitive function over time. But I think when people try to do things that are boring or tedious, it's like a New Year's resolution, it goes down the tubes within the space of a couple of months. I mean, here we are, early February. Think about those of you who made resolutions, how they're doing now, right? All right, so the second part, I feel like I can be even more concrete about, and that is physical exercise. So physical exercise, the evidence that this is good for the brain, for the health of the brain, for the health of cognitive function, is overwhelming. And I think you've probably heard this at other Parkinson's seminars you've been to. But in terms of, and there's lots of different types of exercise, for cognitive health, I think the evidence is best for aerobic exercise. So you don't have to go out and start running marathons or necessarily do an aerobics class, but engaging in activity to get your heart rate up a little bit, that gets you to the point where you have to work a little bit to carry on a conversation. That's aerobic exercise. And you want to have at least 150 minutes per week. So that's 2.5 hours. That means 30 minutes 5 times a week, which is within everyone's reach, but most of us don't do it. And having that number, I think, really can be very motivating because you can track how you're doing week to week. And what I encourage people to do is track it for a week. And at the end of the week, if you didn't make it, well, you flush the last week and you start over again. But you really, if you have that target number, I think it's better than just a platitude of, go out and exercise. Now, all this other verbiage that I have pasted in here, this is also from that American Heart Association website. And basically, you go to the exercise part of it, you click on it, and it starts to give you some detail, including the detail about the 150 minutes a week. And then, what's our biggest hurdle to exercise is getting motivation and making the time. And they have some very concrete recommendations for how to overcome those things and ways to approach reaching your goal of 150 minutes a week. And if you click deeper into the program, it even gets to the point where, I don't think I have it here, but it gives you some more information. And it'll even get to the point where it'll give you exercise paths near your home. I mean, it's really a very well done website with a lot of practical information. So I really think this is a great resource for people who are trying to get started on this. So here's the walking path. So this is again, from the website, and it takes you right to this and gives you recommendations on apps and that sort of thing. All right, so again, I always worry that people think, or that I will, as a physician, be eager to reach for the medications, but the lifestyle issues are very important, and I don't want to forget about them. But now let's move on to talking a little bit about medicines. And you I think, all know that the brain chemical that is most important in Parkinson's disease is dopamine. And the medicines that we use to treat the movement problems in Parkinson's disease are medicines that boost dopamine in the brain in one manner or another. And it turns out that the thinking problems in Parkinson's disease are affected not only by dopamine, but by another brain chemical, and the name is acetylcholine. Okay, and the system of brain cells that make that chemical are called the cholinergic system, the cholinergic pathways. And those pathways are damaged in Parkinson's disease. And when they're severely damaged, that's part of the cause of cognitive decline and dementia in Parkinson's disease. And the reason I'm teaching you all about neuroanatomy and neurochemistry is because this is very relevant to the medications. Okay, so there are a number of medications out there that block that pathway, that block that brain chemical that's really important for learning and memory and other cognitive functions. So two that are sometimes used for the tremor in Parkinson's disease are these first two medicines, trihexyphenidyl and benztropine. Now, I'm not telling you that you should never be on those medicines. What I'm telling you is that if you're having cognitive troubles, those medicines might be contributing to that, and you should think about, in concert with your doctor, adjusting them. So those are two potent medicines that block that transmitter that you might be getting for the sake of your Parkinson's. There are other medicines that you might be taking for other reasons that coincidentally block that brain chemical. One class of medicines is an older class of antidepressants, and amitriptyline, for example, is in this category. And that can block this chemical and can cause some cognitive troubles. And then there are also over-the-counter medicines. So this is the other thing that's important to emphasize. Benadryl, the old antihistamine, blocks that chemical, and in sensitive individuals can really aggravate cognitive problems. So when I see a patient who is struggling with cognitive issues, I'm always careful to not only list their prescription medicines, but get a sense of what their non-prescription medicines are, and make sure that we can remove any medicines that might be interfering with this other chemical system. So if we're trying to sustain this cholinergic system, we want to get rid of the anti-cholinergic drugs. And then there are also pro-cholinergic medications that are available. And please understand that this is not something that everybody with Parkinson's should be on, but if people are having cognitive troubles, these are options to help with those troubles. So the first one I've listed here is called rivastigmine. And rivastigmine was formally tested to see if it would help in Parkinson's disease dementia, and it helped enough that the FDA approved it for that purpose. So that's one of them in the class. The problem with rivastigmine is it makes people nauseous and vomit. So it's kind of a bad side effect. It's available in a skin patch, but there's another medicine, donepezil, which is in the same class. You may have heard of this medicine under its brand name, Aricept, and that's usually the first one that we use when we want to use a medicine in this category. So again, the message I'm trying to give is that there's this chemical system called the cholinergic system. And when we look at medications to optimize function of that system, we can remove the things that make it worse. And if appropriate, we can add things that make it better. All right, so that's the main thing I'm going to say about medications. Maybe something else I'll just comment on briefly is that the medicines that are used for the movement problems in Parkinson's, the relation of those medicines to cognitive function is that they, at high doses, can sometimes promote hallucinations, which obviously interferes with thinking quite a bit. I guess the other message that I want to be clear on is that when we're dealing with motor function, movement problems in Parkinson's disease, more medicine is usually better. When we're dealing with cognitive problems, more Parkinson's medicines aren't going to work, but looking at this other chemical and optimizing the medicines there makes the most sense. All right, so let's get off medicines and see, are there other things, excuse me, other things that we can do? Well, one of the other things that contributes to cognitive troubles in Parkinson's disease is problems with the blood supply to the brain. So again, all the recommendations for heart health hold. We talked about aerobic exercise, we talked about diet in general, but really paying attention to your other vascular risk factors, we call them blood vessel risk factors, cholesterol, blood pressure, body weight, and so on, are worth attending to in the context of Parkinson's disease to maximize cognitive function. And the Stroke Association, Heart Association website is very good about giving people advice on them. I know when I'm giving this advice, everybody sort of rolls their eyes and says, oh, we already know this stuff. But the fact is, only 2% of the American population really meets the guidelines. So almost all of us have some work to do in this area. So that's why I keep hammering on it when I am talking about things we can do. What about other things beyond what's delineated in the Heart Association guidelines and beyond those medications? Well, two of them that are very important are sleep and mood. And these are things that can have profound effects on cognitive function. When they are not attended to, they are very bad for the health of the brain, not only in the short term, but in the long term. These are things that you really want to not ignore if you want to retain your cognitive health. So in terms of sleep, most of you are familiar with something called sleep apnea, obstructive sleep apnea. It's recognized by people snoring a lot at night, having brief episodes of interruptions of breathing. And patients who have this are often sleepy during the day. But then in terms of the long-term risk to the brain of not treating this, there's an increased risk of stroke. There's an increased risk of all-cause dementia. And those are really irreversible risks from sleep apnea. So it's not just a little nuisance, it's something that really is important to treat for the sake of the health of your brain and your cognition. There's also some very interesting research about how toxins are removed from the brain during high quality sleep. This scientist who's responsible for these figures is Jeff Iliff. His name is at the bottom. I should have updated the slide. He's at University of Washington now, but he's really a leader in this field. And it's just another reason to emphasize the importance of getting good quality sleep if possible. Sleep is also often tied up with mood problems and with depression. And the stress of depression is really just bad for the brain directly. Again, it's not just a short-term problem, but it can have long-term adverse effects In this figure, the figure that says control is showing you a healthy brain cell, and that higher magnification figure here on the right with all the little bumps on it. Those little bumps are synapses. Those are the synapses on the brain cell. And when you have chronic stress from depression or from other things, the health of the brain cells actually declines. They lose their branches and they lose their synapses. So this is a vivid illustration in animal models that depression and stress are very bad for the brain. And when depression is present, it really needs to be treated. And treatment can take the form of counseling or medication, or often both. And sometimes there's a bit of a stigma around depression. Depression is very common in Parkinson's disease, and it's just not good to let depression go untreated. So please bring that up to your provider and use the resources that are available to address that. All right, so now we're down to the third of the four topics, and this is what do we need to learn? What are the things that we still don't understand? And I have to say this is going to be very abbreviated because there's a lot of things that we still need to learn. But one of the key things is, well, what is exactly happening in the brain to cause the cognitive decline? I emphasize that that cholinergic system kind of withers in Parkinson's disease. That's one thing, but what else is going on? Some people have suggested that the things that are called Lewy bodies, Lewy, in Parkinson's disease, we've known for a long time that the cells that make dopamine accumulate something called a Lewy body, and we think that is what makes the cells sick and eventually die. The Lewy bodies in early Parkinson's disease are confined to the part of the brain that governs movement. And there is a theory and some evidence that those Lewy bodies spread to the thinking parts of the brain, and that's why thinking functions get affected later in the disease. Another possibility is that in addition to the Parkinson's process, there could be a second process occurring, Alzheimer type changes in particular. And then one of the other possibilities is that there may be specific processes that are tied to certain genes, that there might be a genetic influence that affects this. So I'll just give you a sense of this. This is a picture of the Lewy bodies, this pink illustration on the right. Can you see my cursor? Can I have a thumbs up from Anissa? Or okay, so I'm putting an arrow around the brain cell. That's a brain cell that makes dopamine. It's got some black pigment in it. This pink circle, that's the Lewy body. That's not supposed to be there. So that's abnormal. And again, in early Parkinson's, those things are confined to the parts of the brain that govern movement. But what happens over time, the theory is that the Lewy bodies start in the spinal cord and below the spinal cord, and then and they're already in the lower parts, the lowest parts of the brain, even before people have symptoms of Parkinson's, before they're diagnosed with Parkinson's. Then when it gets up to this area here, that's the area where the dopamine cells are, and that's when people get diagnosed with Parkinson's. But then over the next 10 years, they spread out to the cerebral cortex, which is the thinking part of the brain, and that may be why some of the cognitive problems come along. So this is not the whole story, and some people have doubted whether it's an important part of the story or not. But there is some evidence to support that as one of the ways that this process occurs. And there is some effort to interrupt that process that I'll describe in a couple of minutes. There's also some evidence that sometimes people who start out with Parkinson's also end up with a second process in the brain. It's an Alzheimer type change, which is a little different. We know that occurs in some patients. We know that some of the genes that predispose to Alzheimer's, if you have Parkinson's and you have that gene, you might have a little bit increased risk of dementia over time. But while we're talking about genes, I want to talk about one in particular that has become a focus of research in this area, even though it only accounts for a portion of the patients. And this is a gene that is abbreviated as GBA, and it's a gene that we have known about for many years, like since I was in training, because it was associated with a different disease. It was associated with a disease called Gaucher's disease. Children who have 2 copies of this have a terrible neurologic disease. So this is the way that you get 2 copies of the gene. Each of your parents has 1 copy, and that means they each give 1 copy to their kids, and some of their kids will be unfortunate to get both bad copies. And those children will develop this disease, Gaucher's disease. As I mentioned, we've known about that for a long time. What we've learned recently, which is relevant to Parkinson's disease, is that these people who just have 1 copy of the gene, they don't get Gaucher's disease, but they're at increased risk of getting Parkinson's disease. And that's something we've learned just in the last 10 years. This is not a very common gene. It's present in 1 out of 40,000 people, but that's not vanishingly small. So it's become clear that if you have 1 copy of this gene, you're at increased risk of Parkinson's disease. It turns out about 5% of people, even though the gene is quite a bit more rare than this in the general population, right? 1 in 40,000, 5% of people with Parkinson's disease have this gene. So it's a small percentage of Parkinson's, but it's overrepresented compared to the general population. And the reason this is relevant to the discussion we're having today is if you have Parkinson's disease and you have this gene, the risk of progressing to significant cognitive decline is greater. It's not uniform, but it's greater. So this is one of the things that a number of scientists around the country have come to appreciate in the last few years, and it's led to an effort to really do some clinical trials that are focused on that gene. So as I said, this is a very superficial treatment of what we need to learn. And then I want to say a little bit about what research is underway and base it on those 3 phenomena that I mentioned: the question about the spread of the Lewy bodies, the question about whether some coincidentally intercurrent Alzheimer's changes could occur, and whether other genes are affected. So with respect to this idea that the Lewy bodies are spreading throughout the brain, there is work underway to interrupt the spread of that process by giving people antibodies directed at the Lewy bodies, antibodies directed at the alpha-synuclein. And this is basically how it works. So in the Parkinson situation, these Lewy bodies are inside the cells over here on the left. They get squirted out and they get taken up by other cells. And that way they pass from one cell to the next, and they cause the disease to spread throughout the brain. These little green Ys on the right, those are antibodies. And if we give people these antibodies, they bind up the bad stuff, and it can't be transmitted from one brain cell to the next. And then the brain is healthier over time, which sounds like a fantasy, but the truth is it's been tested quite extensively. We participated in the phase 1 and phase 2 studies, which are very encouraging. The phase 3 study is underway now, and we'll be hearing the results of that in the next couple of years and see whether we know that it's binding up the abnormal material. Whether that is having the desired effect on the quality of life of the patient is what we're going to learn in the near future. The second phenomena, whether there might be some of the Alzheimer type changes occurring at the same time, is also being addressed with antibodies directed at those other features. Those studies the clinical studies are underway. They're a little earlier And it remains to be seen whether that's going to be effective or not. But just to make the point that this possibility is also being addressed in terms of clinical trials. These are not in Parkinson's disease just yet, but if they're proven effective, it would be logical to try to transfer that to Parkinson's disease. The third possibility is the idea of trying to do studies that are directed at specific genes. The fact that we knew about this gene because of this other disease, 30 years ago, means there's been a lot of research into the chemical pathways that that gene works on. And that means that we can go into clinical studies with some knowledge about how that gene works. And if it works the same way in Parkinson's as it did in Gaucher's, then maybe we can develop some therapies there. So there's a trial that was completed in the last few years that went like this. We and the other participating sites invited our patients to participate, and the first step was they would have genetic testing to see if they have this gene. If they didn't have the gene, they were not eligible to participate in the study any further. But if they had the gene, they were eligible, and then they were randomized to a study of a medication that targeted the metabolic pathway associated with that gene compared to placebo. And then the patients were followed over the course of a year to look at their change in the rate of progression and also in the rate of change in their cognitive function. So this was the first time a study of this type had been conducted in Parkinson's disease, and it was completed successfully. Unfortunately, the drug in this case did not do the job. It didn't work the way that we wanted it to, but the data generated by this study is going to pave the pathway for further studies in this area. And there's also an effort underway to do large-scale testing for these genes and really be prepared for the next trial that comes down the pike. So you're going to hear more about this, I think. The goal overall is to really develop a precision strategy, and this illustration, I think, makes this point very nicely. We've got this whole population of people, the population at large, and our traditional way to make a diagnosis is we make it based on their signs and symptoms. All right, so this is everybody with Parkinson's disease, and they're all different colors because they all have different versions of Parkinson's disease. We give them all the same pill, and some people get a lot better, some people get worse, and some people have no benefit because they have different versions of the disease. If we could sort the population out and really define people according to their genetic makeup or some other character, then we could tailor the pill to the patient, right? So the blue pill goes with the blue patient, the green pill with the green patient, the orange pill with the orange patient. It's tailored to their biology. And then the hope, and this is all a theoretical cartoon right now, but the hope is that then everybody will derive benefit because their medication will be tailored to them. And that's going to be an ongoing effort in Parkinson's disease and other diseases. So again, when I described to you what research is going on, that was just a snapshot, a very superficial representation. If you are interested in finding out what clinical trials are available, there's a government-maintained website called it's called clinicaltrials.gov, and the address is just www.clinicaltrials.gov. And your tax dollars pay for this, so you might as well take advantage of it. Every reasonable clinical trial has to be registered on clinicaltrials.gov. So you go to that website, and then you'll see a window like you see in the lower right here, and you just you can select where it says recruitment status. You probably don't want to hear every study ever done. If you click on the one that says recruiting studies, or it says not yet recruiting, that means it's going to be recruiting. Then you can find out what's active, and you just put Parkinson's disease in there, and then you are on your way, and you can see what's available, and you can figure out what's available in your area. Another option is the Michael J. Fox Foundation has a program called the Fox Trial Finder. To look at clinicaltrials.gov, the first one I described, you don't have to give them any information. You can just get on there, you can surf, you can look for what you want. No information gets shared. The Fox Trial Finder is trying to match the person with the trial. So if you wanted to use this, you would have to share with them information about yourself, but then they would try to find a trial for you. For those of you who might be in my vicinity or even in shouting distance, you can look at this website and we can tell you what's going on in terms of clinical research. So that brings me to the end, and I parted with tradition and finished almost on time. How do you like that? So,
well done with all of that information. We do have questions, and I tried to aggregate them according to the type of question. So I want to start with one earlier on at the beginning of your presentation. You're talking about early on percentage of people that develop mild cognitive impairment and then dementia. So there was a question, and I think many people want to know this. How do you tell the difference between normal aging memory loss and memory loss that could be connected to Parkinson's?
Yeah, that's always a tough question. And one criterion is if it's severe enough to interfere with your ability to function, it goes beyond normal aging. The next step is, so if it's more subtle, physicians have at their disposal a set of screening tests that are brief tests that can be done in the clinic. There are sort of normal ranges there, and the clinician can give you some feedback on whether you're falling in the normal range or not, usually in the course of a usual visit. And we're supposed to do one of those in Parkinson's patients. They should have a test like that once a year, okay? And then the third criteria, if we're not clear on whether it's significant or not based on those two levels of assessment, the third level is usually assessment by a neuropsychologist. So that's a PhD psychologist who's trained in administering cognitive tests and defining whether it's outside the range of normal. So again, is it interfering with everyday function? Where do you score on the screening tests? And then a neuropsych test, a neuropsych evaluation if necessary.
So we had a really interesting question that came in just a little bit ago. So I'm going to go to that first. This one says, my husband's cognition is worse after lunch into bedtime. What test will help determine if he has PD dementia? He could never sit for testing for more than an hour as it's difficult for him to sit still. How can he get genetic testing for GBA gene? He is an Ashkenazi Jew.
Okay. So there's multiple questions in there.
Yes, there's lots wrapped up into that. Kind of going. So I thought I'll just have to read it, and you can break it down as you see fit.
Yeah. So for starters, he should have a cognitive screen, and you don't have to sit for an hour for a cognitive screen. Yeah, cognitive screen. There's a test called the MoCA, M-O-C-A. That's the Montreal Cognitive Assessment. Most neurologists like to do that in Parkinson's disease because it hits the right areas. There's a couple of others, the mini mental state exam and the slums exam. Each one of those would give some sense of the level of impairment. Now, people with Parkinson's often do have these fluctuations, and testing them during the fluctuation might be challenging, but you should start with a cognitive screen like that. In terms of GBA testing, the Parkinson's Foundation is currently sponsoring a program to provide genetic testing for the top 7 genes for Parkinson's disease. And the program is called PD Generation. So if you just Google PD, and it's generation, but the G-E-N-E is capitalized. you can find out where you can participate in that. The nice thing about it is it's free. So you can get it done at no cost to you. It's done in a clinically approved lab, so the results are shared with you. And that's an easy way to do it. And then there's also embedded in that a process for giving the feedback in a formalized way. I will say there's one other way to find out your GBA genotype, and that is with 23andMe. The problem there is there's no counseling or anything like that. So.
This is an interesting question. We have so many, but I think this is one maybe many people need to know. Can a severe fall cause cognitive problems or decline?
Okay, a severe fall. So, if someone has a concussion, if someone has a brain injury, and you don't have to be hospitalized to have a brain injury, you can have a concussion. That could accelerate cognitive decline. If someone has a severe head injury, and for example, has a blood clot forming on the surface of the brain, that can also cause cognitive decline. That's more of an emergency. But the fall in and of itself, if the brain is not injured, shouldn't affect cognition.
So I know we had several questions related to diet. And I will let everybody know that next week we actually have a program specifically on what to eat and what not to eat that's going to break down some of those things and may answer some of these unanswered questions. But I had a couple of people actually ask about checking homocysteine levels.
Yeah. Homocysteine is something you can measure in the blood. It's an amino acid. Elevated homocysteine levels in the blood have been linked to cognitive decline and dementia, both in Parkinson's disease and in the general population. Studies have been done, not in Parkinson's disease, but in the general population, to try to lower homocysteine in people with elevations and see if that helps their cognitive outcome. And it did not. Okay. So the standard of care is, for the most part, to ignore this, which I think is actually something that needs some further attention. Homocysteine is not a very expensive, blood homocysteine is not a very expensive test to do it. The reason that it is relevant to Parkinson's disease is when you're on levodopa, your homocysteine level goes up. And it can be lowered typically by taking modest doses of B vitamins. Some alternative practitioners will sell you very expensive versions of B vitamins that you probably don't need. Just like a regular multivitamin or B complex would probably bring it down if it's high. But I think, I guess the message I would give to everybody is if you're not getting your homocysteine level measured on a regular basis, that is within the standard of care. If you wanted to go the extra mile, you could ask your doctor to get your homocysteine measured. But I would not buy into this idea of having to spend an arm and a leg on brand name B12. It's just overstated. I bet this is going to be addressed next week too. So I'm glad you're doing that. It's a longer discussion, and we're actually we're going to start some more research on that topic here. But
fascinating. Okay, so there's been a couple of questions. I think they might sort of go together. And I think this is something everybody would benefit to know. Okay. So can you speak on UTIs and cause of cognitive problems? So delirium.
Yeah.
And then also the next thing, because I think a lot of times people end up in the hospital for that. So additionally, if we're going to talk about hospital, can you talk about the effect of anesthesia on cognition and persons?
Yeah, those are great questions. So let's start with the UTI, and uh, what I should have emphasized and that I didn't is that the onset of mild cognitive impairment, the onset of dementia and Parkinson's is a very slow, gradual process. It's really kind of sneaky. And when people tell me about it, they have trouble telling me when it started. When there's an abrupt change, when people have an abrupt change in their mental function, that means something else is going on, and frequently it's a urinary tract infection, or it's the beginnings of a pneumonia. It's a some infection somewhere. Sometimes it's a medication that got started that was having an adverse effect. But an important message is that abrupt changes in cognitive function mean something else is going on. It's not just a neurodegenerative process. There's something else going on. And the other message there is that when there are these acute changes, if the underlying problem gets recognized and treated, people will often get back to their previous level, right? So if it is a urinary tract infection or some other infection, a course of antibiotics will get them back pretty quickly. It's not something that typically causes permanent cognitive problems or irreversible effects. The anesthesia question is a lot harder because the facts are less clear. The good news is that there are some anesthesiologists doing some good work on that, and including a Dr. here at OHSU. But it's probably a combination of factors. One is what the patient's state is going into the surgery. Are they particularly vulnerable to the effects of anesthesia? Are they sort of on the threshold of dementia, and the anesthesia unmasks that? Another one is, or another possibility is, does the nature of the anesthesia or the other medications that are used during the hospital stay, does that promote problems? So these things are all actively being sorted out, but there's not a blanket recommendation for what to do with respect to anesthesia right now.
Okay. And I think we have time for like one more question, even though we have a bunch of really good ones.
Okay.
And this one was related to those with young onset Parkinson's. Is there a different trajectory or expectation of any cognitive changes for that group?
That's very good. So most people with younger onset have a lower risk of dementia. So in terms of years of disease. So there's some exceptions to that, but most people with young onset, when you look at the bigger studies that are looking at age, young onset seems to carry a little bit lower risk of dementia. We talked about genes. One of the genes that is associated with somewhat young onset is a gene called LRRK2 that some of you have heard of. And LRRK2 is associated with a lower risk of dementia, whereas so LRRK2 and GBA both associated with increased risk of Parkinson's disease. One increases the risk of dementia, one and as I'm making these statements, these are all pretty solid statements, but this is all in evolution, I guess, as we know.
Fantastic. Well, unfortunately, we're out of time for these questions, and there's just been so many good ones. I apologize. We had some questions about sleep. We do have a program coming up at the end of February on sleep issues. The diet one's next week. There's one on coping with cognitive changes coming up. So even though it might not be Dr. Quinn taking on these questions, maybe some of these will be answered in some of our upcoming events. So check those out. I would also recommend, because we put a lot of links in and you want to keep those, if you will go over and save your chat. And the way you do that, if you're not familiar, if you go where you are typing your questions in the chat box, if you over onto the right hand side, you'll see 3 little dots. And if you click that and it pops up, it says save chat. So that will click and it'll save chat to your computer. And that way you'll be able to go back and review all of those links that we gave you. So check those out. And I just want to say thank you to Dr. Quinn for this amazing presentation. It was very helpful, I think, for a lot of us. And I want to thank everyone for joining us. And we have a tradition here at PMD Alliance as our way of thanking our speakers and showing our gratitude. And that's giving you the collective wave of thank you and gratitude to you. So thank you, Dr. Quinn. We really appreciate you and taking the time and giving your expertise.
It was my pleasure, and thank you for the invitation. Look forward to working with you in the future.
All right, everyone have a great day. Thank you so much.